Um, the one of the toughest things about being a medical student is figuring out what to do, right? You're in a new place all the time. You have a bunch of new preceptors. Everything switches around, and you spend half your rotation figuring out where to be and what to wear. You learn something. Hopefully, you learn something new from each physician you work with. I'm going to show you something that hopefully you can apply to every rotation. It's something I've noticed that it's becoming a less and less common in medicine, and that's actually examining a patient. So I want to talk to you about today. If all else fails, examine the patient. In our world, we work with a lot of nurse practitioners and PAs, and they can help a lot, but in some health systems, they function pretty independently at urgent cares, and I will get patients with a certain diagnosis based on imaging studies with no exam. I see patients from the ER with no exam. I talk to ER doctors on the phone and get no exam, which sounds striking, but it happens every day. So that's what I wanted to talk to you about. If all else fails, examine the patient. Your power to provide care comes from your ability to diagnose what's going on. Your differential diagnosis is the most important thing you can have. Too often, physicians cripple their ability to help their patients by being narrow-minded. Every back pain patient isn't a disc bulge. Every knee pain patient isn't arthritis or meniscus tear. And unfortunately, we have a lot of physicians who only have 2 diagnoses for knee pain. And I want that to be different for all of you. So, no financial disclosures. So my objectives for you all for this presentation is to have a good understanding of the responsibilities of being a physician. What's your job? And also be familiar with the pertinent physical examination tests that you need to evaluate patients with musculoskeletal complaints, and then also maintain a broad differential diagnosis when evaluating your patients. So who am I? I'm from Southwest Missouri. I grew up in a small town near West Plains. I went to Drury University here in Springfield, went to KCU in Kansas City, did my, back then, internship. My year was the last year that we had internships, and then residency in Youngstown, Ohio in orthopedic surgery, then did a fellowship in spine at Texas Back Institute in Dallas. Now I work at CMH in Bolivar. Go ahead. So that's me. And who are you? That's the question. What's your job as a physician? Well, has anybody ever looked that up? What's a physician? Well, I did. And you can read it there. A healthcare professional, such as a dermatologist, internist, pediatrician, or urologist who has earned a medical degree, is clinically experienced and is licensed to practice medicine. That does not sound like a very accurate job description to me. So that's what I'm going to try and help you guys with today. Here's our responsibilities as a physician, and they're in order of importance. Number 1, to diagnose. Number 2, prognose. And the least important is to treat. We are only as good as our differential diagnosis. Go ahead. Because if all you have is a hammer, if your treatment is just one thing, everything looks like a nail. And that happens a lot, especially in spine surgery and orthopedic surgery. We tend to be very, very narrow-minded. When we have a good solution for something, we put patients in that box of that something because it's easy to treat. Getting a differential diagnosis does include imaging studies. Go ahead. And knowing when to order those imaging studies. But you should do your physical examination first so you know what studies to order. Because if you haven't seen or touched the patient yet, you shouldn't have any degree of differential diagnosis. Because if someone comes in with hip pain, where's your hip? Patients don't know where their hip is, and you don't know what they mean by when they say their hip pain. Some say back here, up here, down here, all over here. Hip pain to me means nothing because I don't know what the patient's talking about until I examine them. Go ahead. Number 2, prognose. To prognose means educating and involving the patient in their care, specifically shared decision making. Go ahead. So you empower the patient to make an informed decision, and you set appropriate expectations. That's very, very important because when you give a patient a specific diagnosis, you have to tell them what that means. And that happens a lot. Surprisingly, to me anyway, I diagnose a lot of people with cancer. And that's always surprising to me because I'm an orthopedic specialist. That shouldn't be my job. Someone else should have figured that out before the patient got to me. But it happens multiple times a week. Go ahead. And then the last thing and least important thing we do is treat our patients because we must know the cause or the diagnosis to accurately treat the patient. I could do the best hip replacement in the world, but if their pain was coming from their SI joint, I didn't help the patient at all. So the more tools you have in your toolbox, the better equipped you are to help your patients. Like I said, if all you have is a hammer, then everything looks like a nail. But if you have multiple ways of treating similar things, you can give the patient the right treatment, not the other way around. So how do you build a good differential diagnosis? Number 1, you got to listen to the patient. Like I said, hip pain can mean a lot of different things to a lot of different people. So you have to listen to their definition of a hip pain. You have to do a thorough physical examination. And if you're not comfortable touching people, which I wasn't in the beginning, you either got to get over it or do radiology or pathology, somewhere where you don't need to touch people. Because the number 1 complaint that patients tell me about physicians that they've already seen and they're coming to me for a second opinion is they didn't even touch me. How can they know what's going on? And early on, that was very surprising to me because I didn't know the patients really needed that. So don't ever be afraid to touch a patient. They're expecting it. They would be disappointed if you didn't. So I'm going to give a couple scenarios of some musculoskeletal complaints. I'm going to ask you guys some questions so you don't fall asleep. And I'm going to try to give you a few pearls, diagnosis pearls and exam tests and finding pearls so that hopefully you can leave today with a little bit broader differential diagnosis and a few tools in your tool bag or your armamentarium of physical examination tests. So the first thing I'm going to talk about is wrist pain. Go ahead. So differential diagnosis for wrist pain. How do you get the differential diagnosis? You got to ask questions first, right? So you got to ask the typical questions. Where's your pain? Is very, very crucial. That's the first question I ask. Where is the pain? What is it like? What makes it better? What makes it worse? Because that starts to formulate your differential diagnosis. So here's a guy with wrist pain, and I asked that question. Where's the pain and what's it like? He points right there. Now, what do we do next? Does anybody have a differential diagnosis for wrist pain in that spot? What we do next is examine the patient, right? But what would you think? Yeah, and what's the test for that? Yeah. So, very good. But it's very, very important, and it's something that I mentioned earlier. You're going to see a lot of patients that have not seen a physician, that have only seen a nurse practitioner or a PA, which is okay, except you cannot trust any diagnosis ever. You have to get your own diagnosis. I see this a lot, and I see patients that come to me with the diagnosis of carpal tunnel syndrome, and it's not. This was just actually a very similar scenario last week. Patient came in with the diagnosis of carpal tunnel syndrome, and it wasn't. And all it took was one single exam test, Finkelstein's test. That was it. Go ahead. So Finkelstein's test, all you should know what that is. Have them grab the thumb, ulnar deviate the wrist, and that reproduces their pain at the base of the thumb. What is de Quervain's tenosynovitis? It's tenosynovitis or inflammation in the tendon sheath of the first dorsal compartment. It's treated easily with anti-inflammatory medications and an injection. Once in a while, we need to operate on it, but really not very common. Go ahead. So another scenario with wrist pain, same thing. You got to ask the questions first. Where do you hurt? What is it like? Go ahead. So this patient has burning pain, tingling at night while driving, loss of sensation to the fingertips, dropping things, pain radiates up the arm. What's your differential? Somebody throw something out. Okay, what else? Okay. Yeah, carpal tunnel syndrome, ulnar tunnel or Guyon's canal syndrome. Any other? Yes, radiculopathy. Yeah. You can be as broad as you want to be because we haven't even touched the patient yet. And you need to be as broad as you can be right now in this scenario because you don't know. With carpal tunnel syndrome, what's an exam test we want to do? Okay. What else? Okay. How do you tell the difference between carpal tunnel and radiculopathy? Oh, good. Anything else? I'm glad you brought that up. Yes and no. It depends on who reads it. I've got a neurologist who I've seen 2 negative EMGs and 1,000 positive for carpal tunnel, and that's it. And I have a PM&R guy who gives me the exact answer, but they both do an EMG. So don't trust the EMG unless you trust the person who does it for you. But you still shouldn't trust it anyway because you have to do a physical exam. Go ahead. So carpal tunnel syndrome, where are they going to have numbness? What nerve's affected? Median nerve. So if you ask the patient that, I've got numbness and tingling, wakes me up at night. Where? They're going to go like this. 100% of the, well, 99% of the time, it's my whole hand. It's not their whole hand, but they're going to tell you it's their whole hand. So what do you do then? How do you know? I say, where does it start? The thumb side or the pinky side? Then it makes them think a little bit and make them commit. Is it mostly, or does it start on the thumb side or the pinky side? Where they say it is carpal tunnel syndrome, where are they going to have normal sensation? Yep. Where else? And where else? That's the palmar branch of the ulnar nerve, or the median nerve that comes off before the carpal tunnel, which means they should have normal sensation in their palm. Now, that's not something they're going to tell you. I have normal sensation in my palm. I guess they're going to say it's their whole hand. So when you test sensation, specifically test the palm, because if they have numbness in their palm, then it's coming, they either have an aberrant palmar branch or it's compression higher up in the median nerve somewhere. So Phalen's test is a really good test. Tinel's test is a good test too, but it's really, really hard sometimes to be provocative unless it's really bad. What exam findings will you see looking at a hand with carpal tunnel syndrome? Yeah, thenar atrophy. When you see it, you won't forget it. So you got to look and compare, and I always rub their thenar eminence so I could feel the muscles itself. I want to feel, are they full, are they flaccid, are they hard? If they're right hand dominant, it should be a little bit bigger on the right most of the time. Not all the time, but expected. Does typing on a keyboard cause carpal tunnel? No, it doesn't. What does? Using tools that vibrate, like a chainsaw, a weed eater, something, a vibratory tool is linked to carpal tunnel. And that's what you're doing with the Tinel's test. Tinel's test is not just hit it. I try and reproduce a vibrating tool with my finger and hit it hard and fast. Tinel's test, you can't just do it for a second or two. It's an awkward 60 seconds. Go to the next slide. And you have to do it. You can't have the patient do it. You have to do it. So that's one of the first things I do in my exam for a patient with wrist pain. Is I sit right in front of them. I flex their wrist, and then I start asking questions, because then it makes it not so awkward. By the time I'm done asking questions, then I ask, is this making it worse? And then I do the Tinel's test, because hopefully I already inflamed the median nerve enough that the Tinel's test will be a little bit more accurate. Go ahead. So hopefully that gave you a little bit of pearls there. Elbow pain, same thing, differential. You got to ask the patient where it hurts and what it's like. Go ahead. And be specific. So this patient, he's got pain over his lateral elbow with activity. And he grabs his arm like that. What's your differential? Okay. He gave you that with the tennis racket. What else? So you should start super broad. You can tell me tumor. You can tell me aneurysm. You can tell me arthritis. You can tell me anything right now, because you don't know yet. And if you approach the patient with lateral elbow pain with lateral epicondylitis as your only differential, you're going to miss a lot. You have to make them prove it to you. Go ahead. There's a lot going on in the elbow, a whole lot going on in the elbow. It's a very, very complex joint with muscles across both directions, a lot of nerves. Elbow is very, very complex. What provocative tests can we do to rule in or out lateral epicondylitis? There's really only one good one. Yeah, resisted extension. Go ahead. With the arm extended, elbow extended, wrist extended. You don't want to do it like this guy. This guy either has really, really, really strong fingers or he's not pushing very hard. I use my whole hand because I want to know, does it hurt or not? I make them prove it to me. So another patient comes in. Go ahead. Lateral elbow pain, hurts right here. What's your differential? So you do the Cosen's test, it's negative. Then what do? You push on the lateral epicondyle, it doesn't hurt. What do? You got to broaden your differential and start thinking outside the tiny little box of lateral epicondylitis. So you have to have some other tests in your armamentarium And those specifically for this is the resisted supination test and the extended middle finger test. Does anybody know what those are for? Go ahead. Radial tunnel syndrome. It presents a lot like lateral epicondylitis. And I guarantee every physician has missed it. The radial tunnel is pain. The radial tunnel is the PIN coming out underneath the supinator, which is about 5 centimeters distal to the lateral epicondyle. Go ahead. There's no, the PIN after that does not have any motor branch or sensory branch, at least cutaneous sensory branch. So they're not going to have numbness. They're not going to have weakness, just like lateral epicondylitis. But it's treated completely different because it's two completely different things. So if you engage that supinator muscle, then you're going to make the symptoms worse. So that's the resisted supination. Go ahead. There's the difference, really. Super, super close. And the patient's going to tell you my elbow hurts. So radial tunnel syndrome is where that arrow is. Lateral epicondylitis, where that arrow is, very, very close. You have to have both in your differential to really figure out what's going on. Go ahead. So hopefully that's just a couple pearls for elbow pain. Shoulder pain. This patient has achy pain at night. It's worse with sleeping. They describe as a sharp pain with reaching, pulling, and pushing. What comes to mind? Right? There's a lot of things right there. Go ahead. There's nerves, joints, more than one joint. There's actually 3 joints right there. There's muscles and tendons. It can be anything. Shoulder pain, when you walk in and see the patient, can be anything. Go ahead. We always think of rotator cuff problems, right? So that's probably one thing we want to rule out from the beginning, rule in or out. There's a lot of tests for a shoulder exam. That's a whole lecture in and of itself, but I wanted to put some up there to show you. If the pain is coming from a joint, it will be reproduced by moving that joint. You just got to move in the right direction. But that's a good way to rule in or out where the pain's coming from. Because if you do the Neers test or the Hawkins test, those are 2 really good tests for impingement syndrome and at least rotator cuff tendonitis. You basically try and pinch the rotator cuff, right? Have you all got to do that yet on rotation with anybody? What does the rotator cuff do? It's 4 tendons, right? Controls motion of the arm. Internal rotation, external rotation, abduction. So those are the things that these tests do, is test those specific muscles, tendons, to see if they're torn or if they have some type of pathology. Most commonly, patients will have rotator cuff tendonitis. We don't think of it as tendonitis, but that's really what it is. Less common, they have a rotator cuff tear. But you should be able to know if they have a tear based on your exam, not an MRI. Because if it's torn, it's going to be weak. You're going to have a positive drop arm test. You're going to have weakness to abduction or weakness to internal rotation or weakness to external rotation. So you should know before you even order an MRI. The MRI is only for the insurance company, so they'll pay for the treatment, really. Okay. That's just a picture of the torn rotator cuff. You can imagine those tendons are torn, they're going to have weakness. And you want to always compare to the contralateral side. Always examine both shoulders. Okay, this patient has shoulder pain again, burning pain at night, cannot sleep, achy pain with activity, radiating into the hand. Sounds very, very similar. Go ahead. This is I really like this picture because it's so true. I see a lot of patients with mid-back pain, thoracic pain, shoulder pain. Those are all the same thing. If you look on that back, you don't think of that as being cervical radiculopathy, but it is. And it's very consistent complaint with cervical radiculopathy is pain along the medial border of the scapula, most commonly C6, C5. But you have to include that in your differential and do a good neuro exam to know if it's shoulder pain, is it scapulothoracic syndrome, or is it cervical radiculopathy? So with cervical radiculopathy, obviously the exam is paramount. You have to know if there's any neurologic impairment or not, because that really dictates treatment. So I'm a spine surgeon. I operate on a lot of spines, but I operate on people, not an MRI. So almost everybody has a bulging disc. The question is, what is that bulging disc doing to the patient? Go ahead. So cervical radiculopathy, right? You got to know your myotomes and dermatomes. There's a lot there on those charts, but actually pretty straightforward. Starts with C4, top of the shoulder, wraps all the way around the arm, right? 4, 5, 6, middle finger 7. How hard is that to remember? Not hard at all. 8, 9, 10, 1, 2, wraps around the arm. So it's very intuitive. The myotomes can be a little bit more difficult. Go ahead. Everybody gets C6, C7 myotomes mixed up, right? Is wrist flexion C6 or C7? Does anybody know? Wrist flexion? 6, extension 7. So there's the old, back when in the olden days in the 1900s, when we had textbooks, they used to say a waiter's tip. Everybody heard that before for C7? So when a waiter asks for a tip, they do it nonchalant, reach behind their back so you can put money in their hand. So elbow extended, wrist flexed is 7. So waiter's tip is 7. 6 makes kind of like a 6. Flexion of the elbow, flexion of the wrist. I'm sorry, extension of the wrist. Did I say it backwards? Okay. Wrist extension is 6, wrist flexion is 7. Obviously, it can be very confusing, but that's how I remember it. Waiter's tip. So the key is being consistent and doing the exam the same way every time. It makes you more efficient while you're doing the exam. It also makes you more efficient when you dictate your exam or when you put it in the EMR. Go ahead. Reflexes, yeah. Correct. And that's very common. You can definitely have mix. The key is to know what's affected by the patient, meaning where's the weakness compared to the other side. And that way you have a baseline to say, okay, is it getting worse, getting better? How aggressive do I need to be? And where do I need to look? So it's giving you a roadmap to your differential. So if they have weakness with wrist extension, we say that's 6, but in your differential, you need to be a little bit broader than C6, right? They got weakness further down. Just like with examining carpal tunnel, I left that out, but you got to examine the whole arm. If they have a neurologic complaint, you got to know, is it coming from the median nerve at the wrist? Is it coming from the brachial plexus, or is it coming from the neck? Right? So reflexes help with that too. If they have abnormal reflexes, with reflexes, you look at symmetry. Everybody has different degree of reflex, normal for them. Some people are just hyporeflexive, some are hyperreflexive. You got to compare to the contralateral side. The order in which I do my neurologic exam is very, very important to me because it makes it flow a lot easier. My sequence is do the reflexes first, and I can do all 3 reflexes with the patient's arm draped over my arm. Makes it very, very comfortable. And if you do the muscle testing first, then they get really confused. Do I pull? Do I push? Do I relax? What do I do? So I always do the reflexes first, then I do my sensation exam, and you compare to the contralateral side. Is it numb over here compared to over here? Then you do special tests, and then the last thing I do is the motor exam, because then you're asking them to push and pull, and they can get confused if you do that first. When you do a motor exam, you gotta again make them prove it to you. There, especially with back pain, neck pain. Just got in a wreck. My back hurts. My neck hurts. Call my lawyer. Sometimes they're there for secondary gain. So you got to be able to figure that out. Go ahead. So grading of muscle power. Again, compared to the contralateral side, explain what you want them to do very well. Be very specific on what you're asking them to do. It can be very difficult because it's something I do every day, all day. So I kind of can go kind of quick. But to them, it's their first time someone's doing an exam on them. So they don't know what you're asking for, right? Remember that? Yeah, it's a lot harder than you think. Encourage the patient to use maximal effort. You need to be able to tell, are they faking it or not? And you want to be able to really perceive weakness, because the grading scale is 0 to 5. What's the difference between 0 and 1? Okay. Contraction. Is there any, or is there a little? Is there none, or is there some? And how I know is I feel the muscle. If I don't get any strength, then I have one hand on the muscle and one hand doing the resistance, so that I can feel if the muscle's contracting or not. And always remember grade 3s, motor or strength against gravity, right? They can lift their ankle up, then they have at least grade 3, right? If they can't, then they have less than grade 3. So that really kind of helps me right off the bat. Can they do it? Then they're at least at a 3. So shoulder abduction test. This one is surprisingly accurate. Does anybody know what this means? Got shoulder pain, it hurts at night. The only way it relieves it is if I put my hand behind my head on my pillow, and then I can go to sleep. If you have impingement syndrome or rotator cuff tendonitis, is doing this going to make it worse or better? Yeah, worse. That's my favorite question, one of them to ask. Do you sleep with your hand up by your head? Yeah. And that's probably radiculopathy, not something to do with the shoulder. Because they will say, and they'll come in, and sometimes you don't even have to ask, Doc, I can't sleep. The only way I can sleep is have my arm up. Oh, better look at your neck then. Go ahead. Vermeet sign is something easy to do, and you got to check the range of motion anyway. So you have them flex their head all the way down and let it sit just for a couple seconds. And if it reproduces paresthesias in their arms, then it's a good indication that they have some pathology in their neck. Burling's test, somebody mentioned that earlier. That's a good provocative test. I like to keep things very, very simple. Turn their head and smash down on it. I'm reproducing compression, right? The opposite of cervical distraction, compression. Honestly, I don't always do Sperling's test because by the time I get there, I've already done all the other tests, but it is something to keep in your armamentarium. Go ahead. Or your neurologic exam of the upper extremity. Figure out a pattern, be consistent, do it the same way every time, and you won't miss anything. Or the back. Back pain is the #1 reason people go to the doctor of everything. #1 is back pain. There's a lot of different causes of back pain, and it's our job to figure that out, right? Go ahead. That's how we figure it out. Memorize that chart and you're good to go. Go ahead. So, causes of back pain. Is it coming from the back? Is it coming from the spine? Only 2/3 of the time is it coming from the spine. It can come from the hip, the SI joint, or something else. So that's just over half, in my opinion. Is it really coming from the spine? So you have to have a very broad differential when it comes to diagnosing back pain. Go ahead. It could be hip pain, right? My hip hurts. You get that all the time. So you have to add that chart to the other chart and then figure it out. Go ahead. Causes of low back pain in patients who've already had surgery. I know a lot of physicians get kind of closed-minded when somebody's already had back surgery because they're not really comfortable with what happened, what they didn't do. It's going to be complex. Sometimes it's not. It's a clean slate, really. You can't put them in the box of, oh, they've got degenerative disc disease. They already had surgery. It can be something else. And as you can see, most of the time, it is something else. Go ahead. So remember, our most important job is to diagnose the cause of the pain, not the treatment. Go ahead. So cause of hip pain. Hip pains are, like I said, my hip hurts. It can be anything. That has to be your differential too, anything. Because it can be SI joint pain, hip arthritis, tendonitis, bursitis, fractures, radiculopathy, kidney stone, ectopic pregnancy. I mean, you got a aortic aneurysm. I diagnosed a lot of aortic aneurysms on a X-ray of a spine. Go ahead. There's a lot of muscles across the hip joint. There's a big bursa there. There's a lot going on in the hemipelvis and the thigh. So you have to keep a broad differential. Go ahead. So 30% of people who see a physician for low back pain really have sacroiliac joint pain. That's a lot. That's almost 1 in 3, right? So the #1 reason people see a doctor is back pain. And almost 1/3 of them really have SI joint pain. Have you guys studied SI joint pain at all? Not a lot? Go ahead. It looks a lot like radiculopathy. That is the pain pattern. Looks a lot like a pinched nerve, right? Go ahead. Pain referral patterns for SI joint. It's front, it's back, it's down the leg, it's into the lateral calf. You don't necessarily think about that when a patient presents with that pattern, but it definitely needs to be in your differential. Go ahead. What do you do to, okay. When you take a history for SI joint pain, one of the key factors is it's worse with sitting. They have pain when they drive, pain when they ride in a car, they have pain at night, can't find a comfortable position to sleep in. That person has their leg out of the car because they're not in a comfortable position when they're driving. So if it's worse with sitting, that really moves SI joint pain up on my differential. The Fortin finger test or Fortin finger sign. Has anybody heard of that? No. That's where you ask a patient, where does it hurt? Show me with one finger. And they point to their PSIS. You say, can you do that again? Show me again where it hurts. You gotta do it twice. They point right to their PSIS. That's very indicative of SI joint pain when they can localize it. And you got to make them. You can say point with one finger and make them commit. If they do this and they can't really find it, then that's not a positive Fortin finger sign. Go ahead. Other provocative tests for the SI joint, there's a lot of them, but we think of Faber's test, right? So flexion, abduction, external rotation, put their ankle on their other knee, push down, really crank it up. That can be, I mean, if they have hip pathology, that's going to be provocative too, right? But it also increases the suspicion for sacroiliac joint pain. Go ahead. The compression or SI compression test, you lay them on the table and you're basically just trying to get that SI joint to grind. That's what I think about in my mind while I'm doing it. I'm compressing that joint, trying to make it hurt. Same thing with the thigh thrust. Yeah, flex their knee, flex their hip, and you push that hemipelvis down. You're trying to rock the SI joint. Traction test, you do the opposite. Cross your arms, put your hands on the ASIS, and you're trying to rock the SI joint open. The Galeson's test is a rotational provocative test. You get one leg off the table, the other leg up, and you're trying to just rock their SI joint. So 3 of those tests are positive. That's a very high suspicion of their pain coming from your SI joint. And like this slide shows, the Patrick's test or the Faber's test, 77% sensitive, 100% specific. The thigh thrust is 80% sensitive, 100% specific. So they can be very, very indicative. The anatomy of the SI joint. We don't think of it being the largest joint in the axial skeleton, but it is. It's a really, really big joint. That's a lot of opportunity for pain. That's why I think it's more common than what most people think. The SI joint does move. You all know that because DOs. We already know that. It does move. Go ahead. Risk factors for sacroiliac joint pain. Leg length discrepancy. Usually you got to check a little harder than that. But that is one thing to check. Do they limp? Do they have scoliosis? Do they have tilted pelvis? Are they pregnant? A lot of times patients will say, my back pain started right after I had, or during my first pregnancy, or right after my second pregnancy, or whatever. That always increases my suspicion for a sacroiliac joint pain. There are very few 100% in medicine. This is one of them. 100% of the time, if you have an ACL tear, you will have quad atrophy. 100% of the time, if you have a fused spine from ankylosing spondylitis, you will have sacroiliitis. Those are 2 100%. You should keep those in mind. So anyone with ankylosing spondylitis will have sacroiliac joint pain. Now we have a really good fix for SI joint dysfunction as a sacroiliac joint fusion. The reason why it was ignored so long is because we didn't have a fix. So we just brushed it under the rug. There was no real good fix for it. Now there is. You can do a rhizotomy, you can do injections, and you can do a fusion if those fail too. So low back pain, often referred to the hip. Low back pain is commonly caused by arthritis in the spine, but can be muscles, facet joints. Go ahead. Probably the most common pain generator in the spine itself, in my opinion, is not the discs, it's the facet joints. You have 2 facet joints behind every disc. They're designed to take 20% of the load. Your disc is designed to take 80% of the load. If you have a bulging disc, to me, that means you're overloading your facet joints. And that's all it means to me. Go ahead. When you hear a patient say, my back went out again and I was on the couch for a week, that is most commonly facetogenic pain or pain from overloaded facet joints. Now we have a real good way to address facetogenic pain. That's called a rhizotomy. So keep that in your differential, because in fact, and like I said, more commonly, back pain is caused by the facet joints than it is the disc. So if we treat the disc and just the disc and leave the facet joints alone, they're still going to have back pain. The common scenario with facet joint pain is a twisting and flexion moment. And patients will tell you, I know what is going to happen. I know I moved wrong. They'll say, I went to put my sock on or tie my bootstraps and it set it off. And then I was down for a week. Wash my foot in the shower. They give those scenarios because it happens to them over and over again. They know exactly what's going to make it set off. And they'll get a little twinge in their back and then they know they're out for a week. So keep that in mind. Facet arthritis, I took this in here. Hip arthritis. Go ahead. Very common question I ask. I mentioned putting a sock on. For patients who have hip pain and it's in their groin and that's high in my differential, I ask them, do they have trouble putting on their shoes and socks on that leg? And they will give you the answer, yes or no. And that really hones me in on if it's hip arthritis, because you get decreased range of motion, right? You get big bone spurs, sclerosis. That's my number one favorite question to ask a patient with hip pain. Do you have trouble putting on your shoe and sock? Because I'm ruling out a lot of other things, right? SI joint, radiculopathy. The exam is for hip pain is the most crucial aspect, because if you move somebody's hip and it doesn't hurt, it's not coming from their hip. And I see that a lot. Someone diagnosed with hip pain, it's really radiculopathy or SI joint pain or the opposite. And all it takes is moving somebody's hip. That's literally all it takes, is touching a patient and moving their hip. As you can see, it's not, if you get an x-ray, it's really not that hard to diagnose. You can tell the difference between those hips, even in the back of the room. It's very, very obvious. But they can have a hip that looks like that and have full range of motion and not hurt and not coming from their hip. It could be coming from stenosis in their spine. So if you move their hip, even with an x-ray like that, and it doesn't hurt them, then you got to broaden your differential out again. Go ahead. You can skip that one. So lumbar radiculopathy, we talked about that a little bit, but let's get into it a little bit deeper. Go ahead. Lumbar radiculopathy is sciatica. I hate that word, but it's what it is. Pinched nerves in your lumbar spine causing pinched nerve pain down your leg, right? Go ahead. You get neurologic impairment with radiculopathy, right? You just like in the cervical spine, you have to do a good neurologic exam in the lumbar spine. And I do the same sequence. Reflexes first, then sensation, special test, motor testing. You just have to memorize those charts to have a good differential. And sometimes you examine a patient and maybe you don't remember, is it wrist flexion or wrist extension for C6? You can think about that later. But if they have weakness, you need to know it. If you didn't test for it, you don't know it. Go ahead. Reflexes, again, we look for symmetry. I don't use a little hammer because I do it all the time, so I use my fingers. But when I test, especially the patellar tendon reflex, I always put my hand on the thigh because I want to feel the contraction of the quadriceps. And really assess how much contraction there is, do one and then do the other. Clonus is something very, very important to assess. And And that once you feel it, you'll never forget it, right? Yeah. Once you feel it, you'll never forget it. And it's such an easy test to do. And it has huge implications on the patient's outcome if you miss it. So neurogenic claudication. Claudication is pain with walking. You can get claudication neurogenic or vascular. You got to be able to figure that out. Do a good neurologic examination, you'll figure that out. Go ahead. I want to get to this specifically, myelopathy. Does anybody know what myelopathy is? You can answer if you want. Okay, spinal cord compression, go ahead. So it's a spinal cord injury due to compression of the spinal cord. Where does the spinal cord end? Close. We got one, but it's not S1, right? So if you have a huge disc herniation at L4, you can't have myelopathy. You just can't. What's one of the key differences in myelopathy versus radiculopathy? Huh? Myelopathy does not hurt. It does not cause any pain at all. In fact, I see patients who literally have been in a wheelchair for 9 months, can't walk, and just came in to see me because they didn't think anything was wrong because they didn't hurt. Or the opposite, which is even worse. Multiple times, patients come in a wheelchair, can't walk for 6 months, had a lumbar MRI, seen multiple providers, multiple physicians, and nobody figures it out because they don't hurt. And everybody thinks if you have a spinal cord injury or spinal cord compression, it should hurt. It doesn't hurt at all. In fact, I remember one patient specifically who did not believe me, wouldn't let me operate on them because they didn't hurt. How do you check for myelopathy? Upper motor neuron science. I mentioned clonus. Very simple test, very indicative of myelopathy. So with radiculopathy, you're going to have hyporeflexia. With myelopathy, you're going to have hyperreflexia. Cauda syndrome. That's compression of the cauda equina, right? So that's below the conus, usually about L1. Go ahead. Spinal cord, cauda equina syndrome is acute compression of the cauda equina, right? Very simple to remember. Acute compression. I see a lot of people with like 100% stenosis that don't have cauda equina syndrome because it was very slow to form. Go ahead. Most common causes herniated disc. What are the test question, exam findings, symptoms you hear about cauda equina? Yeah, bowel and bladder incontinence. What else? Right. What else? Weakness and numbness. We forget that one all the time. Weakness and numbness. What kind of incontinence? Stress incontinence? No. If you have back pain and it hurts to get up in the middle of the night, grandma, 80 years old, gets up and pees her pants because she has a sharp stabbing pain in her back. Is that neurogenic bladder? Neurogenic incontinence? No, that's stress incontinence. And that's something you have to, that's literally your job. You have to figure that out. If they're incontinence, stress incontinence, or truly neurogenic incontinence. If they get up out of their chair and they look down and their chair's wet because they peed the chair and didn't feel it, that's neurogenic incontinence. Or if they look down and their pants are wet and they didn't feel it, that's the saddle anesthesias. They can't feel it. They have no idea they peed their pants. Go ahead. So that's a good example of a very large disc herniation. It has to be severe stenosis, and it has to be quick onset stenosis. Go ahead. There's one. Go ahead. Get to this. Give that. There's one thing you need to do to prove it's cauda equina syndrome. Anybody know what that is? Huh? Yep. That's the medical and legal definition. Because if you do a DRE and they have normal rectal tone, they go home and then they get acute cauda equina syndrome and they come back 2 days later and it's too late. Well, Your Honor, I did the exam and it was normal at that time. And then you're clear because you did it. If you don't do it, well, Your Honor, I didn't think it was cauda equina syndrome. Did you do a DRE? No, I didn't. Patient didn't want it. That's the difference between losing that case and winning that case. And it's the difference, more importantly, with patient getting a good outcome versus a bad outcome. Go ahead. So anytime and every time you expect cauda equina syndrome, check their sphincter tone. Good for you and good for the patient. Go ahead. A little bit. I threw this slide in here because a lot of people don't know the difference between neurosurgeon and orthopedic spine surgeon. The difference is orthopedics, we are trained to treat problems with bones, joints, muscles, tendons, ligaments, which is the most common cause of pathology in the spine, right? Every orthopedic surgeon that does spine surgery has to do a fellowship. Neurosurgery, they're trained to treat brain and nerve problems like tumors. They can do fellowships, but they don't have to do fellowships. So you want to keep that in mind. You want to send your patients to somebody who probably did a fellowship in spine, so they have that extra year training. Just to recap, our number one job is to get the right diagnosis. The way you do that is a good exam and be consistent. If you do the same exam every time, number one, you dictate it a whole lot quicker. You can just say normal lumbar exam, and then you, boom, you got your whole exam done. The one you did and the one you dictated. Go ahead. Neurologic exam can be very, very complex, but if you do it the same every time, it becomes very, very routine. Go ahead. So this is what I want to leave you with. Just because you have not seen a particular diagnosis in clinic does not mean that diagnosis has not seen you. Picture. You see it? You see it? Anybody else see it? I'm in on the. Just because you didn't see the diagnosis doesn't mean it didn't see you. And you won't know it unless you look for it. So, any questions for me? Anybody done musculoskeletal rotation yet? Ortho or sports medicine or no? So, okay. So hopefully you guys learned a few new tests, and hopefully you will broaden your differential diagnosis and actually do an exam. Don't get too busy and too lazy to not examine patients, because that, I can tell you, is the standard of care. And I think after me telling you that and you looking on your rotations, you will see that I'm right, unfortunately. So I have for you guys.